Appreciate you all being in your seats and ready to explore federalism as it's practiced today. I flew back from Chicago today. I had meetings in Chicago yesterday, so got up early and got on a plane. And of course, O'Hare was shut down for quite some time with lightning, and I was a little nervous I wasn't going to make it back on time, but I did. I happened to be reading a book, Gods and Generals, about the Civil War. And it kind of reminded me a little bit. I thought maybe I'd do a real quick historical frame for people. There's a lot of young legislators here. Back when I was first elected in the 1990s, the federal government and the state governments had quite a few disagreements, but mostly it was about unfunded mandates and about the federal government kind of owning up and funding programs. There weren't a lot of protracted court battles, and there weren't a lot of programmatic bills that were done that were, larger than a small pickup truck can hold. So it's a blessing, I guess, to live in interesting times. The Affordable Care Act has reset a lot of things in the United States. We're 4 years in, and we're still not done with some of the court discussions and court decisions. We just had a decision come down which calls into question whether states that have a federal exchange instead of a state-based exchange can actually subsidize individuals who register for insurance through it. This is an interesting period. I mean, I don't think anybody would have thought in the 1990s it would have been normal for the governor of Texas to mobilize the National Guard using state funds to go to the border, kind of in contravention of what the Border Patrol was doing. So these are interesting times for us to have a discussion, and we've got a great panel for you today. Access to quality and affordable health care, that's the real goal and the point. And how do we get there is one of the big questions. Is it possible to craft a pathway through using the Affordable Care Act kind of as a superstructure to find what we need to do to serve the people of our states? Most state policymakers have thought all along that affordable health care and access to insurance was important, but many weren't comfortable with the idea of a one-size-fits-all mandate out of Washington, D.C. In some ways, the Affordable Care Act is a set of structures that are difficult to work with, but in other ways, there's a lot of opportunity inside the Affordable Care Act for innovation by the states. Health needs in Illinois, where I live, may be very different from those in Indiana or Vermont or Connecticut or elsewhere. And how can, inside the Affordable Care Act, we adapt to the current environment and provide the kind of public policy necessary to make sure that the people of our states are well served? Now, the real good news is I'm not going to try to answer any of these questions for you. We have got a first-class panel of people on the front lines of innovation at the states. Each of our panelists is going to take 3 to 5 minutes to discuss one or more innovative approaches to healthcare planning that's happening at the state level or being discussed at the state level. After that, we'll ask the panelists a few questions and then open it up to the audience for participation. I'm going to invite the audience to share their innovative ideas and that are being discussed in their legislature, but we're going to try to avoid, if we can, policy statements or open disagreements. This is really about innovation in healthcare in the states. Joining me up here are the experts. First, Patricia Miller of Indiana, chair of the Senate Health Provider Services Committee. Jim Dunnigan, from Utah, is the co-chair of the Utah Health Reform Task Force. Between those two is Mike Fisher. He says we can call him Fish if we want. Good guy from Vermont. He's the chair of the House Health Care Committee. And on the far end, who just joined us, experienced probably some of the same airport delays that I dealt with, is a guy who led the National Governors Association for more than 20 years, a well-respected personage up on Capitol Hill who understands the depth of state policy, who's the current professor of practice at the Frank Batten School of Leadership and Public Policy at the University of Virginia. So we're going to start, I guess, with Patricia. Pat?
Thank you. I'm pleased to be here, and I very much appreciate the opportunity to discuss what Indiana has done. In 2007, we actually passed legislation to establish a health care plan to cover our uninsured Hoosiers. So before there was an Affordable Care Act, we actually had legislation, and we're moving forward with covering those individuals. We began in January of 2008 to actually have the plan available to individuals. I want you to know that we do care that Hoosiers have health insurance and health coverage. My colleagues and I were very concerned about them, and so we did come with this plan, and we looked at consumer-driven priorities and principles as we put together a plan. So essentially what we have put together is a plan where the state essentially underwrites the insurance premiums for our uninsured Hoosiers, and it is combined with a medical savings account type of plan. We call it a power account. Individuals use the power account first, and then they go into an insurance plan. There are 3 insurers who they can purchase their insurance from. It's Anthem, Blue Cross Blue Shield, MedWise, and Managed Health Systems. The way it works is that the state essentially pays, obviously, the vast majority. Those individuals pay based upon their income, with those at the lowest level of income, at the poverty level. And by the way, this goes up to 200% of poverty. And I'm talking about the way we implemented it in January of 2008 because the ACA has had some impact on this plan. However, on the payment from the individuals, and there's a mistake on the handout that I prepared for you, those who have the highest income pay up to 5% of their income for their premiums, but no one pays more than 5%. Those at the lowest level of poverty pay up to 2% of their income. But generally, when we started the account, people paid about $11 per month for their insurance coverage. Today, we have raised it. It's $160 a year. They spend out of their power account first. We have as a part of our plan that they must get wellness coverage. It's not mandated, but there is a penalty for them if they don't do it. And wellness would include things like an annual physical for women, depending on the age, would be mammograms, pap smears. There's a whole list, but it would be cholesterol screenings and the like to ensure that people have good health outcomes. And we believe that this has been a very good plan. It is a Medicaid waiver. We were granted a 5-year waiver initially. We have since reapplied. The 5-year waiver was reinstituted as a 1-year waiver, and then we came with the second 1-year waiver. So we've had this plan altogether for 7 years. We have currently applied for 2 waivers. One would be to continue the HIP program, Healthy Indiana Plan, that we have now. The second is for the Healthy Indiana Plan to be used as our Medicaid expansion under the Affordable Care Act. We have been in negotiations with the federal government for approximately 2 years. Our governor is personally involved in this, and so I guess I would say we're cautiously optimistic about our being able to continue with the Indiana plan. I would like to share with you just briefly the outcomes. We have good health outcomes, and I'm just going to read you some percents of what the people who are in the plan tell us. 95% of the enrollees in the HIP coverage are satisfied with the plan, and 98% said they would re-enroll. 93% of the members make their power account payments on time. Individuals who use this account have less emergency room care. 60% of the health members receive preventative care similar to what commercial insurance does. 80% of HIP members choose generic drugs versus 65% of those in the commercial market. We believe these are very good outcomes. We're very pleased about that. We're pleased that the people want to continue the plan. We have asked the survey how many would be willing to pay more on their monthly payment. Remember, we started at $11 a month. The vast majority would be willing to pay $5 a month more, and there's a great number who would be willing to pay $10 or more for their present coverage. So they very much like the Healthy Indiana plan, and we believe it's good for Hoosiers, and we are working with the federal government to use this as our Medicaid expansion, but we will not opt in to the federal Medicaid expansion the way it is. So thank you.
Sure. Good morning. Yes, good morning, everyone. Again, my name is Mike Fisher, and I've been a state representative for 14 years in Vermont, and am now the chair of the House Health Care Committee. When I'm not a legislator, when I'm not being a politician, I am a social worker on the front line, visiting families in my community, families with young children who have been dealt sort of the toughest hands you can imagine. When I come to an event like this, a meeting like this, and listen to my colleagues from other states, I often have a moment, or I've had a moment of, wow, we're doing pretty well in Vermont. 7% uninsured rate, well on our way with payment and delivery reform, state innovation model, implementation level. We have been well on our way with a medical home model, which we've been working on for a number of years and is starting to show this year for the first time real savings, not only good outcomes for patients, but real savings. But when I'm back in the community, either as a politician or as a social worker, I see the other side of it. We come here and celebrate how well our states are doing, and I'm going to speak on the other side. As good as we're doing in Vermont, I know what it's like to visit with somebody who has insurmountable medical debt because they've done such radical things as have a baby or have a mental health crisis. I know what it's like to have people who say they can't get the care that they need because the out-of-pocket costs are beyond their ability to pay. And when we run those numbers, pre-ACA numbers, we see, about a third of Vermonters, remember I said 7% of Vermonters are uninsured, about a third of Vermonters are uninsured or underinsured. That is, they have high out-of-pocket costs. And I know what it's like to watch people who choose not to get care. Now, when you don't get care, sometimes the condition just goes away. But often, the condition just gets worse, and it leads to worse outcomes and more expensive acute care. And so I feel a sort of urgency when I'm in the community. So we took a very different step. We've moved in a very different direction in Vermont. In 2010, we passed a bill that set up the basis for participation in the exchange, but also called for our administration to seek a waiver from the exchange as soon as available, and to pursue a more unified healthcare financing system where all Vermonters have to pay according to their ability to pay, and all Vermonters would have access to a defined essential benefits plan. It's a very different model. It's one that recognizes healthcare as a public good and is, in all honesty, aspirational still. We're still in pursuit of it. Now, recognize, I'll just say a word about the term single payer. I have a governor who likes to say the term single payer. I think my name may have been mentioned with single payer next to it. I until this moment, haven't said the word single payer. I don't call it single payer because, in all honesty, there will always be multiple payers. There will always be Medicare. There will always be people who have insurance from an employer or retirement coverage from an employer out of state or federal. But we believe we can wrap around those other coverages and provide a better, more unified system, and a system that frees us to really pursue payment and delivery reform in a different way, and frees us to be able to start to take action on. Policymakers often say that the economic and social conditions that are more important determinant of someone's health or a population's health than what happens in the doctor's office. We recognize that all the time, yet we spend a great deal of our energy focused on what happens in acute care, in the doctor's office, or in preventive care. And so I believe that moving towards a more of a unified system, a system where it is public dollars, will force us to take the steps that we know we need to take in terms of improving a population's health. So the bill, like I said, calls for a waiver from the exchange, and calls for and sets up a number of triggers that have to take place before we can move towards Green Mountain Care, what we've called Green Mountain Care. And those include, no small task, passing a financing plan and a budget through the legislature, and getting a set of assurances from an independent body that we've set up that this move will reduce administrative costs, will be financially sustainable over time, and will reimburse providers at a rate sufficient so that we can attract and retain a high-quality workforce. So that's the step that's before us, and as we go back to the legislature in this next year, that is what we are working on to move forward. So, thank you.
Jim, there's a microphone just to your right. I'll make the other one back. No, just to your right. Oh, you're going to do it from the podium? Sure.
Good morning. I'm Jim Dunnigan from Utah. And in Utah, the Affordable Care Act has challenged us to be innovative. Similar to you, it's pushed us to change some of the methodologies that we've been using and try to come up with better ways to do things. And I'd like to share just 3 examples. First of all, we preserved the legislature's policymaking role. Now, 4 years ago, we passed a law that said that before any state agency or department implemented any portion of the Affordable Care Act, that they first had to let the legislature know that they were going to do it. Did not prohibit or prevent them from implementing it, but they had to keep the legislature in the loop. And then 2 sessions ago, we passed a law that said that before the governor implements any form of optional Medicaid expansion, he has to obtain approval either from the legislature in a regular or special session. Secondly, we obtained approval from the federal government to operate our own SHOP exchange while having the federal government operate the individual exchange. Initially, the federal government told us that that was not allowed, it couldn't be done, and that the bifurcated approach was not permitted. But now, along with Utah, several other states are also doing that model, and that the feds are operating the individual marketplace, and we are doing the SHOP exchange or marketplace. And thirdly, we are also addressing the coverage gap according to our own priorities and our own values. As alternatives to simply expanding Medicaid using the traditional payment and delivery system, we've looked at 3 approaches to assist those that are in the coverage gap. The first was strengthening the existing charity care network. We have a lot of providers and hospitals that provide charity care in our state. And so we're looking at strengthening those and trying to use those to pick up a portion of the coverage gap. We also looked at creating a state premium assistance fund to help people purchase insurance. And third, to use the ACA's enhanced Medicaid funding to create a premium assistance program, somewhat similar to what Arkansas and Iowa have done. So let me say a quick word about these 3 options. During this past session, this past January as we met, we appropriated $2 million to fund additional primary care. We believe that primary care is valuable and is critical, and we get a big bang for our bucks by helping people obtain primary care. So we provided an additional $2 million to provide primary care coverage for up to 40,000 additional Utahns. Some of those are in the coverage gap and others are not. Second, we debated but did not pass a proposal that would have expanded our existing Medicaid program up to 100%, and we were willing to put $35 to $40 million of state money, and this is the twist of state money, regardless of whether or not the federal government was willing to match to cover those folks. However, that idea did not pass. We saw it as perhaps a realistic alternative because it would allow us to do it on a defined contribution basis where the amount of state money going in was fixed and determinable by the legislature, but that idea did not pass. And then thirdly, we considered 2 additional proposals to implement a premium assistance program. One was to use the more traditional or federal government proposed match where you go to 138% of poverty and expand them into the traditional Medicaid program. And then one proposal was made by our governor, and this is also building along the lines of the premium assistance idea where you expand to 138, but you do the Arkansas-Iowa model of helping people purchase commercial or private coverage and doing premium assistance. And that, the governor is still pursuing that. That did not pass, but it's still active. We are negotiating with the federal government. I have to tell you, we've been negotiating with the federal government since 1896 when we became a state. It just happens that right now we're negotiating regarding the Affordable Care Act. But our governor met this last weekend with Secretary Burwell. I had the opportunity to meet with her 2 months ago, and I'm working, with the governor on this solution. But it's not done yet. And let me just cover some of the things that we're talking about. In the governor's proposal, it relies on employer-sponsored plans and other private coverage where possible. So if people have access to employer-sponsored coverage, we're going to require them to get their coverage through their employer, and we will assist in the premium payment. It includes an exception for the medically frail. They would go in the more traditional Medicaid program. It requires premium and copays for adults between 100 and 138% of poverty. So it would be an expansion from 0 to 138 with some copayments and premiums above 100%. It does ensure that their cost sharing would not exceed what they would pay if they were in the traditional or in the federal marketplace. So our proposal to HHS is we'll have those folks pay similar to what they were paying in that category between 100 and 138% had they purchased through the federal marketplace. It proposes to provide wraparound coverage from Medicaid where necessary, and it includes incentives for employment and work training, healthy behaviors, and proper utilization. We had 36 or more items that we have to obtain approval and agreement on the federal government. So far, we've received agreement on about 25 of those, and now we're down to the sticky ones. It appears that HHS may approve the governor's proposal later this year. However, as I mentioned, the proposal cannot be implemented unless it's approved during a special or general session of the legislature. And some of the legislature likes it, some don't, and there's not a consensus yet. So to conclude, let me just say that implementing the ACA, to put it mildly, has been a real challenge for us. We remain sensitive to the fact that the federal funding, if we expand Medicaid, will impose significant and long-term fiscal obligations on our state, and that it ultimately will compete with other things that we could be using that money for. We could be putting the state's match into education, transportation, corrections, many other places. So we are well aware of that. We're concerned about crowd out and then the jostling with other budget priorities. On the other hand, we're very aware of the hundreds of millions of dollars that Utah is sending in taxes, fees, and other expenses to the federal government that the Affordable Care Act requires. And we do hear their calls to recapture at least a portion of that money through Medicaid expansion. And additionally, we have genuine concern, and we've heard from many of those who fall on the coverage gap and the trials and the challenges that they are facing. So all of this has motivated us and continues to motivate us to look for innovative solutions, and I've appreciated the opportunity to hear from many of you during this conference and hear what your ideas are and your solutions, and I will conclude with that. Thank you.
Thank you. Ray? He turns it on from over there.
Oh, okay.
Yep, you're out.
Thanks. I'm going to take a little bit broader view, and part of my comments are going to be based on watching this legislation go through when I was in Washington, and part of my comments will be a little bit more academic. The first comment is you have to understand that this is probably, the opportunities under this waiver are enormous, and that if this act actually had gone through conference with the House, it never would have been this broad. So when you look at the history, what basically happened was Ron Wyden from Oregon, very late in the process, came forward with this. Caucus did not want to do it, but when you need every Democratic vote to get the legislation done, you give in. So they gave in on this, but it was really opposed by people like Henry Waxman and others in the House. And I would say, I've spent a lot of time on the Hill. The opportunities are enormous. I've never seen any waiver that's nearly as broad as this. So what does it include? It includes everything in the ACA. It includes Medicaid. It includes SCHIP. It includes Medicare. Now, I know the difference between Medicare and Medicaid, and it includes Medicare. It also has language about other health programs that go to the states. And what's really important, these can all be done at the same time, okay? So you can move with a Medicaid waiver, a Medicare type, SCHIP, and then the Affordable Care Act all at the same time. That's very, very big. Second point is we've got to recognize that this is still an innovation or demonstration. It's 5 years. It can be renewed. Sometimes they're renewed a lot. You know, Arizona went in 1982 to manage care for all Medicaid, and they get it renewed all the time. But remember, it is for 5 years. It's not effective until 2017. The reason for that is they really wanted it to go earlier, but CBO put a cost of about $4 to $5 billion on it. They didn't have enough money at the end, so they stripped it out and changed the effective date. So what are the opportunities here? I'm just going to tick off a number. You've already heard basically from Vermont. I think it does actually fit a single payer pretty well. And Bernie Sanders was one of the big supporters with Wyden towards the end of it. So it fits there pretty well. Obviously, a number of the states like Arkansas, I think Iowa's in, that have already done sort of a private sector component, got a waiver for their Medicaid. They're already looking at sort of expanding that. So you're going to see that as an option. You're also going to see, you got to remember that one of the criteria is you've got to basically cover everybody that you would have covered with the original one, and it has to be as affordable. But you got a lot of money there because basically all the money that would go to individuals and businesses can go to government. And government actually has the ability to reallocate that money between low-income people who are purchasing in the exchange and low-income people in Medicaid. So you can do different types of co-payments. You can probably do savings accounts and a lot of other things to hopefully increase the efficiency of people who are purchasing health care. Medicare. One of our biggest problems, as everybody knows here, I think, is dual eligibles, okay? I've had many states come and say, we'll take them over, okay? Federal government will pay for us for a fee. Well, Medicare is in here. And that's one area where I think states can run these dual eligible populations a lot more effectively than the federal government does. Take a fee from it. And I think the federal government may be open to that types of things. So I would look heavily at the people a little bit on the left. You can also create a public program that is in the exchange. So that's another alternative. You might want to make a trial run of it and sort of see how it works. We already see where Oregon, they're trying to accelerate their accountable care organization definitions and driving the delivery system. That's something that they might be able to accelerate under this. We know that Maryland has gotten already their all-payer. They are the one state that sets hospital rates. And they have another plan they're going forward on that. It is conceivable that they can accelerate that under this. So I think you've got phenomenal opportunities here to be creative. Now, what are the challenges in terms of getting these accepted by HHS? The first is I think you have to meet their overall criteria really on how many people are covered And then secondly, on the affordability. But you got to remember what's going to be happening is you're going to be making estimates, hypothetical estimates, going forward from 2017 out 5 years. And that's going to be real tough. It's going to leave a lot of room for negotiation. But you've got to meet those two criteria first off. The second criteria, which is big, is it has to be actuarially certified by HHS actuary. That's big too. So whatever you do from the private sector kind of stuff, it's got to work in the long run. And the third one is it's got to be budget neutral, because OMB is going to be in there from the federal government standpoint. And we used to argue, I mean, a lot of the Medicaid waivers had to be budget neutral every year. You couldn't argue that you were going to take some money up front and pay it back over the next 3 years and meet them. They really required everybody, and I suspect, given the concern of the deficit, OMB will hold to that as well in this. So those are three pretty big hurdles. But I do think there are huge opportunities. I'm not one who thinks, although there's legislation kicking around to move the date up to 2014. I hate to say this, but number one, I don't think that's going to get enacted. But number two, it's going to take states 3 years to get anything thought out and through that system. So any state who's really serious about this ought to, in fact, start now. The only other comment is, we have an election in the middle of this, 2016. We don't really know what's going to happen. Situation might get better for approving these. It might get worse. But I would just stress again, the opportunities are huge. And don't underplay the whole Medicare and the dual eligibles. I firmly believe in terms of potential savings for states. It's a huge opportunity here. Thank you, Mr. Chairman.
Wow. So Ray shares with us that the opportunity for states to innovate, thanks to some pretty thoughtful work by senators at the end, is pretty broad. I don't think I had heard that before or understood that quite as well. In the meantime, 28 states of the 50 have decided so far not to expand current Medicaid, or they're in the process of exploring waiver discussions. What does that mean for coverage? I mean, are the states leaving money on the table? Does it bother you, Patricia? Is it a concern in Indiana that Indiana's not getting, the providers aren't getting as rich a revenue stream as might give them the opportunity to expand their services? Are people being served in Indiana anyway? There should be some more. You have one right there? I gave you a couple seconds. There you go.
Thank you. Well, that's a very good question, and obviously it's not an easy answer. We are trying diligently to actually get the waiver. We believe we can cover all Hoosiers if the federal government will give us the waiver. And so we still believe that we are actively engaged in bringing down the federal money to cover Hoosiers. And I failed to tell you how we funded the HIP program, so I think I'll take just a minute to do that in light of some of the comments here that have been made. Originally, when we passed the Healthy Indiana plan, we funded it two ways. We increased the cigarette tax by 44 cents. And if you want to know why 44 cents, we were already at 55.5 cents, and it was magical that we not raise it to $1 or above. So we went to the max, which was 99.5 cents. But in addition to that, to keep it revenue neutral, to meet the requirements of the federal government, we worked closely with the hospitals, and the hospitals were very supportive. We took $50 million of DSH money, the federal disproportionate share hospital money. The hospitals were ready and willing to donate that into our trust fund dealing with the HIP program. I'm happy to tell you today we no longer need to use the DSH money, that we can fund it fully with the cigarette tax. But as we've projected out to 2020, looking between 2017 and on, we believe the HIP 2 plan, which we are negotiating with the federal government now, can be paid for in the following way. Obviously, we want to pull down all the federal funds, but the way that we plan to fund that is through the continuation of the cigarette tax and a hospital assessment fee. Again, the hospitals are very supportive. We anticipate the state share between 2017 and 2020 would be $1.4 billion, and we plan to raise that. The hospital assessment fee would be $959 million, and the cigarette tax would be $676 million. So we have tried to anticipate and look to the future. But what we are committed to is providing the best possible care for the people of Indiana, and we believe this is a better plan than Medicaid. And not to get into Medicaid so much, but if you go out and look online on the health outcomes from Medicaid, many of the outcomes are not good, and in some cases, they really don't show any improvement over those who are uninsured.
Real quick, is Blue Cross Blue Shield a big player in HIP?
They are. We selected through the going out for bid, we selected 3 companies to provide insurance under HIP. Anthem Blue Cross Blue Shield is one, MedWise is one, and then HMS.
A question I'll come back to all you guys is Blue Cross Blue Shield too big to fail now? In other words, have we got such an investment nationally in the states through the exchanges and elsewhere that pretty much they can determine whatever they want in the premiums, and if they don't raise enough money, we're not going to have a lot of choice nationally but to make sure the Blues survive. I'm going to go to Michael real quick.
I want to say something else about that. I'm sorry. However, I've got the mic. So.
Well, they've all got their own. Get your own mics out, you guys. Oh, sorry.
I don't know where mine is, but at any rate.
I'll have to remember that if I'm on a panel with Michael
That's right.
again.
All right. On the Healthy Indiana plan, and I can't get into all of that with you, but we reimburse under the Healthy Indiana plan at Medicare rate rather than Medicaid rate, which is much more appropriate and we think is much better for our providers. But essentially, people on HIP are using a private insurance, and so they get coverage like we do. The bill goes to Anthem Blue Cross Blue Shield or whomever, doesn't come to Medicaid, and we believe this is a great program. I think it's got a lot of innovation, but the best thing is there are positive health outcomes.
Good. We'll go to Michael. In Vermont, you guys did expand Medicaid to start with. Have you maxed out the Medicaid expansion currently?
So there is such tremendous variation between the states. The Affordable Care Act represented a contraction of Medicaid for Vermont. Okay. So before the Affordable Care Act, we had Medicaid participation up to $150 for childless adults and $185 for caretaker adults, and the Affordable Care Act required us to come back down to $133 or $138. So we've actually reduced our Medicaid numbers by complying with the Affordable Care Act. And then the other thing I'll just mention is that with some of the savings associated with that, we have supplemented the premium tax credits and the cost-sharing subsidies that the feds provide for. One of 2 states, Massachusetts and Vermont, have done that. And I'll say again, despite that, I still think that coverage, access to care, is unaffordable for many Vermonters.
Jim, are there people in Utah not getting health coverage today because you guys haven't expanded Medicaid? Is that a problem that weighs on the legislature and the executive branch?
There are, and we hear about it on a regular basis. Next week we have our Legislative Health Reform Task Force meeting, and on our agenda we'll be hearing from some additional folks. So there are folks who are not getting coverage because we have not expanded Medicaid. There remains, however, for many in that population, charity and community health centers and health clinics, and we gave some money last year to expand those. So we are trying to treat those, but as I said earlier, we are well aware that there are some who are not receiving care.
Well, now, let me tease that out just a little bit. And I'll kind of ask all of you, and you can kind of pipe in. There's a difference between health insurance and health care. Do people on the panel here feel there's people in America that are not getting access to health care? Now, I'm not saying organized, non-chaotic, but I mean, is it a question, is the ACA and what we're doing at the state level a question of normalizing a care system, or is it access? You know, that's always been a thing that bothered me. I would have asserted when I was in the legislature that everyone in Illinois had access to care. Some of it was episodic and not well organized. They showed up at the emergency room and hopefully they got dealt with. If they had a impacted tooth, they got sent away, even though that led to an infection. They got treated 2 days later. But I mean, do you think there's a care gap or an insurance gap in Utah?
People have access to care. I agree with you. I visited one of our community clinics that treats a lot of people with substance abuse. And they have somewhat recently opened a walk-in clinic there. And prior to doing that, they were having many of their clientele go to the ER once or twice a week. Now they can come in, and for either no charge or very minimal copay, they can see a primary care physician. And we track some of those, and they've reduced their ER admission or episodes to maybe 1 per month. So the care's there. I believe access is there, but the proper care and continuity of care probably is not very strong.
Ray, a tough question for you that you can answer now that you couldn't used to answer. What's wrong with those reticent 28 governors? Why aren't they jumping on the board of the Medicaid program? They've been running it for 20 years. I mean, they should have been excited by the expansion, right? What's wrong with Medicaid?
That's a long story. But I think from the state perspective, the pressure in the short run over the next 5 years, of course, is DISH is going to get phased out. So you get $19 billion that's going to be phased out. And I can tell you already, from what I pick up in Virginia and so on, is you got some of the small rural hospitals and others that are concerned. So you're going to get some of these smaller hospitals go out of business. On the other hand, what I think states are concerned about is if we buy on to this, what happens in 8 years? Do we get a per capita cap? Or
Pull the mic closer, Ray. They're having trouble hearing you. If you bring the mic closer.
I'm sorry. What a lot of governors say basically is they're concerned about what happens in the end of 5 years or 8 years. I know personally, I have lobbied very heavy and have held it off for 28 years, per capita caps and other types of caps where people were trying to do basically cost shift to state governments. The component that I worry about is we have a lot of concerns about whether Obamacare is going to work. I have a different concern. I think it's going to work, but it's going to become very, very costly, a lot more costly than they thought. Therefore, we have an increasing deficit problem. And I think at some point Congress has no alternative because Social Security is about 5% of our deficit problem. The 95% of our deficit problem is health care. It's Medicare and it's Medicaid. And they're not going to have any alternative but to come back and do some restructuring. So what I hear in Virginia, that's what it's real, I think, personally.
So you're telling me that even though I served with 3 governors and never heard one of them with a longer time horizon than 4 years, and I love both of them that I worked at, but you're saying it's the time horizon's a problem for governors. Do you have a thought on whether Blue Cross Blue Shield is too big to fail now? I mean, are they really underwriting health care, or are they just pooling the bills and allocating? I mean, you know,
they're huge. They're particularly huge in the southern states. I mean, I think there's many Medicaid programs which are 78, 80% Blue Cross Blue Shield.
A lot of the exchanges are overwhelmingly dominated by Blue Cross Blue Shield. Yeah, so you know, they're not really in marketplace insurer if they control 75% of the market and the government's paying most of the premium and the shortfall, are they?
No, I mean, I think on the exchange side, some good things are happening because you had a number like United and the big boys who have stayed out, who I think are beginning to come in based on some experience and so on. So I think you're going to end up with more balance, perhaps through the exchanges, but I do worry about the Medicaid.
Yeah, last question I'll kind of pose to all of you. The thing that bothered me, and keep in mind when I was in the Illinois legislature, I was kind of a slow learner, so I didn't pick it up too quick. But one of the things that's really apparent is that medical costs, healthcare costs are growing at 2.5, 3 times the rate of growth of the overall economy. In a lot of ways, health outcomes in the United States are not extraordinarily better than they are in other parts of the world where they spend substantially less. In Illinois, at a time when changes in treatment modality would argue that we're about 100% overbedded, I think there's 5 new hospitals under construction in the Chicago metropolitan area. Now, just being an accountant and a recliner salesman and a chairman of appropriation, not kind of the healthcare, not on the front lines, it seemed to me that there's too much money in the system, and way too much of it's going into bricks and mortar and institutional care and care structures, not necessarily care delivery. Do you guys see that as a problem? I mean, when you send the firemen to the fire with gasoline in their extinguishers, you might get burnt. It just seems to me we're growing this. Is that a problem that you see, Ray?
Yeah, in fact, I just finished doing a commission on healthcare cost containment, and we're having a session, I think, later this afternoon on that. It's scary. I mean, the last 3 or 4 years, the rate of increase in healthcare costs has been down, but there's been 2 very comprehensive studies that basically say now 90% of that is a fallout of the recession of 2008 and 2009, and we are going to be back on that trend. The second risk that people are just beginning to talk about, but is very, very serious. On one hand, it's phenomenal, a good thing, and on the other hand, it's bad. But we are on the cusp of major biomedical breakthroughs, and I will point to hepatitis C as the first one. And we don't know whether the new drug that's $80,000 a year is going to be cost effective or not. The British healthcare system obviously thought so. I think they approved it last week. But we're going to have huge breakthroughs. Some of them are going to be cost effective, and a lot of them are not. So what I worry about is not only we're going back to the long-term trend here, but we may end up above that trend.
Jim, can I sell you some of the excess hospitals in Illinois? I mean, I got way too many beds. Can you use some of them?
You know, in Utah, we're fortunate to have amongst the lowest healthcare costs in the country, and there's a variety of reasons for that. And we do have some new hospitals coming on, but they're coming on very carefully and very gradually. And we have some terrific healthcare systems in our state. And just briefly, Blue Cross is a major player in our market, but they don't dominate. They are not a part of Medicaid in our state. And they're important, but there's very viable competition from others.
The Blues, too much money in the infrastructure. How do we make the system more accountable to our kids who are actually paying for this, since we're using all borrowed Chinese money to do this?
So yes, Blue Cross is a significant player in the exchange and in Vermont, in the large group as well. And but I will say also that I find Blue Cross to be a good partner in the reform effort. We're blessed in Vermont to have a distribution, a thoughtful distribution of nonprofit hospitals, and almost as if somebody really planned it. It sort of just happened, but the catchment areas are well positioned. I think that we have to think logically about the purpose of each of those hospitals, and do each of them need to do all of the things that they're doing. But that's a planning question, and we have empowered a board to have quite a bit of power in both setting hospital rates and in setting insurance rates, as well as the certificate of need process.
Indiana, is there do the size of the Blues make you nervous? Do you have too many hospital beds? Are they building hospitals like crazy on your side of the border?
Well, Anthem Blue Cross Blue Shield is obviously a huge player in Indiana, and I suspect in every state. We do have a number of hospitals, but I think the trend is going to turn the other way about building hospitals. First of all, one of the things we found out from our HIP program is patients who have more involvement in decision-making are making better decisions than those who are not. They are asking, people on HIP who have the power account that they spend before they get into the insurance plan are asking the prices of health care. They're using generic drugs rather than name brand drugs. They're being more careful about how they use their health care dollars. But regardless of that, if you look at hospitals, not only in Indiana but across the country, the number of inpatient days, the number of empty beds is continuing to go up, and it's not just because of the economy. There's more outpatient care. There are a lot of things. And in our area, we have a large network in Indiana. It's IU Health, Methodist Hospital, and a number of all combined. There are 19 hospitals in that network. But IU Health is now looking to close a hospital because they have more hospitals than the need is necessary. So I think across the country, you're going to see a decline in the number of hospital beds simply because of the demand. And in Indiana, we still have county hospitals in our counties. And I think you're going to see, unfortunately, some of the county hospitals not be able to compete in the future. But I think the marketplace is going to have a lot to do, and I'm not concerned that the trend is going to continue with more and more hospital buildings.
Boy, I hope you're right. I'm going to invite the audience. We got a mic stand up here. If you make your way up, we'll let you ask the question. You can embarrass the moderator by asking better questions than I do. And while people assemble at the mic or don't come to the mic, we're going to go to our lightning round, which I didn't warn you guys about in advance. The big question, that we kind of all walk around is the cost curves. The growth rate of expense, whether it's innovation in biologic pharmaceuticals or whether it's expansion of infrastructure. In a quick, you only got 30 seconds or 10 seconds each for this answer. How do you bend the cost curve besides rationing? Who's got the mics? Are we down to one mic? There's one right next to you.
Where?
Right in the seat. Okay.
Okay, very quickly.
Bending the cost curve.
Essentially, the biggest problem is you've got a fee-for-service healthcare system. So you're paying for every single procedure. So doctors are going to give you a lot of procedures. You have got to change that system, move it towards an integrated, coordinated care system that basically they are rewarded if they meet quality standards and cost standards. And they have risk at the table. Now, states have to remember that when you add up people in Medicaid, people that get health care from state employees, many states actually purchase it for local employees, plus people in the exchanges, you're approaching within the next year or two 90 million people. It's almost twice as big as Medicare.
Yeah.
So what you've got to do is harness that purchasing power to drive major changes in the delivery system.
So we need to pay our healthcare people more like we pay restaurants. We want a full meal, we want it good, and we're not going to tip you if we don't like it. Quick thoughts on bending the cost curve.
We need to pay for outcomes and not volume. A year and a half ago, we moved our Medicaid population, the majority of it, into accountable care organizations, trying to do that, and the first year and a half have been very promising.
Excellent. Michael, bending the cost curve, you're on the front line.
I'll second the concept. The right care at the right time is better outcomes and saves money. In addition, we spend a great deal of money in our healthcare system that doesn't contribute to anyone's care. We spend a great deal of money, and our providers spend a great deal of time chasing the dollar. Our providers spend a great deal of time complying with the various health plans, and there's got to be a more efficient way of
maybe tort reform too? Or is that one bridge too far?
So
if they're not worried about being sued, maybe we're not going to get that extra test. I don't know.
I'll talk more about that, but not in 10 seconds.
Okay. Patricia, real quick, bending the cost curve.
Okay,
Good question.
I would just like to see that consumers have more information and more decision making, because I think that would be extremely helpful. I cannot ask Anthem Blue Cross Blue Shield how much it costs to have a gallbladder removed and get an answer, because the reimbursement rate is different for everyone based upon what they've negotiated with the provider. And I think it's very difficult for patients. If you get your hospital bill, you can't tell from the hospital bill or whatever what you got, or if you got what you're paying for. I think we've got to have more transparency in the system.
I think you're right. When I was in Illinois and I was appropriations chairman, we had no way of knowing if a Medicaid patient got more than one appendectomy. We had absolutely no way of knowing. Would you please give your name, where you're from, and ask the question of the panel?
State Representative Dave Heaton from Iowa. Iowa's involved right now in a SIM project in approaching healthcare by creating these integrated health systems in the state using our major hospital systems and vertically integrating all the way down to our critical access hospitals. And the doctors then will be sucked into the integrated health system. But what we're being told is that the feds are going to come after Medicare with a capitated approach. In other words, moving away from fee-for-service and identifying the population that's going to be covered and handing the money to the state and say, cover them. We're thinking also that they're going to do the same thing with Medicaid, take money, provide it to the state, and say, take care of that population with this amount of money. We spread it through our integrated health systems, and then there's a bonus if you can get the results that the feds want. The problem I'm having with it is it looks like all of a sudden we're turning the money toward health care over to the federal government and taking the state out. And so in the future, what I worry about is all of a sudden the feds say, we need to reduce the cost of health care, we'll back off the amount of money that we're providing for those identified populations, and we're going to squeeze you. And that's what I worry about. You're going to take the states out.
Isn't that 40 years of federal activity on squeezing rates? The beginning of the Medicare program, they paid the bill you sent. You know, and today, you know, it's negotiations. So I think quick comments on integrated care systems and the risk with federal capitation.
Yeah. First off, I think you're moving towards integrated is a positive thing. You do have a risk that they'll leverage the market, so you have to watch your antitrust and be very clear that you're not going to allow that. With respect to the risks on capping, you're 100% absolutely right. We've now hit a point with our deficit that we don't have much more room. So you're going to see strategies to move in both of those directions. So yes, in fact, you should start staying up an extra hour every night just to accommodate that.
Other thoughts on gap
So,
pay rate?
about accountable care organizations, for me, I feel like there's a great deal of potential for gain. I also have a great deal of fear, and I think you just put it in a different way than I would. I have a great deal of fear that these systems will become giant self-referral systems, more than doing a better job of giving people the right care at the right time.
Yeah, that's one of the risks I've always seen. If we could go to the next question. Yeah, please tell us where you're from. And
all right, thank you. I'm Senator Randy Becker from Washington State, 2nd Legislative District, Mount Rainier. I was in the medical field for 24 years, and my question goes to the all-payer claims database that some states are trying to adopt and others are holding back in looking into that. Can you tell me, I look at what we're doing in healthcare right now is just the foundation, and then we're going to continue to grow and change whatever we're setting up so that we actually give that best patient care, whether it's by state or not. But can you tell me from your perspectives the benefits, the pros and cons of an all-payer claims database? Is it truly transparency, or is it just getting to what has been contracted? And are there other options that are available that we might be looking at that we're not necessarily talking about?
all payers claims database, thoughts?
Yeah, you've basically got about 14 states that are doing this now. The problem is it's very expensive, although it is a very, very robust information base. The Healthcare Cost Institute in Washington, D.C., that was set up by the 6 largest providers, so United, Aetna, Kaiser Permanente, several others, are now collecting all this information. They have now signed a contract with HHS. They're going to get the Medicare data, and they're going to have the Medicare data and the Medicaid data. And I think with the exception of one state, you haven't been able to get the Medicare data. So you ought to contact them, because once they get this up and moving, and it may be another year or so, they're actually going to turn around and make this available for a fee to states. I think it will dramatically reduce your costs. Plus, you'll be able to compare costs. But this database is phenomenal because it goes right down to the individual hospital, and it allows you to focus on who your high-cost providers are.
So may I ask a follow-up to that? May I ask? Just as a follow-up to his question, or his comment, though. So if we're looking at doing that as a state, would we be wiser to wait to utilize that system than expand our dollars and our efforts?
I would talk to them and get a better sense of their time frame.
Thank you.
Quick, go ahead.
So Vermont has an all-claims database that now has Medicare. Are we the one state?
You may be.
And it is
Persuasive governor, apparently. You guys must get everything. I mean, geez.
And it is a tremendous tool. It is a tremendous set of data to help policymakers make decisions. You know, I have sat with somebody with that database to be able to plug in different factors like number of primary care physicians in a given area and emergency room visits, and you can really see relationships between those kinds of things.
Yeah, go ahead.
So in Utah, we're very vested in working on our APCD. We've been working on it for a number of years. I sponsored legislation last year that said by last fall it's got to start generating outcomes and data that we can use. For a few years now, we've been putting and gathering and collating data, but we want to get it out to the consumers to get better pricing, better comparatives. So my legislation said by last fall that agency had to start producing certain data. They did not, so I passed it again this year and said this time I really mean it. But it is difficult, it's challenging, but we are making progress, and that will lead into our decision of whether or not we want to use our own risk adjuster rather than have the federal, because that risk adjuster, that information is also used for that same purpose.
You know, I got to jump back in and say, you know, payment variation, if you look at charts of payment variation between hospitals, between payers, it is crazy making. You look for a single, you know, procedure like a colonoscopy, pretty straightforward, and you look at the hospitals throughout your state, and you'll see no relationship. Well, the relationship between what's paid and what's charged is always more than what's paid, but there's no relation. It's all over the place, and it has to do with patient mix, and it makes the claims database really important tool.
Yeah, although I would, you know, in my experience, every time we came up or saw the federal government come up with a cost control or comparative, there was leakage somewhere else. You wait and watch your codings change as you finally get a handle on the data.
Indeed.
The providers will figure out how to upcode or change the
So
coding.
I would like to say something to that. Having worked in the medical field, we were audited by Medicare, by Medicaid, and other carriers. We actually had outside auditors come into our clinic to make sure that we were not upcoding or downcoding, because you could be penalized either way equally. So when we talk about providers are going to shift their coding, they are held by a high standard. And not all, and they're fraudulent if they do it, but not all participate in that.
Well, no, and I wouldn't say all do. This is a system that has built a series of charges that have no relation to any reality in response to government policy. So I just always worry about tweaking. Just what happens in education after you got 6 years of test data? You change the test. Okay, can we have the next question?
No, we don't wait 6 years to do that.
Hi, my name is Christy Herrera, and I'm with the Foundation for Government Accountability. My question is about Indiana. In looking at the Indiana waiver, it seems like there are going to be a lot of sticking points with CMS. The 6-month lockout for non-payment of the premium, the $25 copay for non-emergent use of the ER, and I think you're excluding non-emergency transportation as well. So with all of those points, how optimistic are you that CMS will approve those measures? And if they don't, do you think Governor Pence is willing to walk away from the Medicaid expansion?
Tough question there.
Well, it is a tough question, but one, I will say cautiously optimistic that we will get it approved. And I say that because we're in negotiations, and we have already conceded a number of things. And for example, when I talked to you about when we first implemented HIP, the $11 monthly premium, et cetera, the feds have said we can't do that. So they've already said we can't charge for that. They've put a cap on the number of childless adults that we could cover. So we're in the process of negotiating, and our goal is to be successful in this negotiation. Are we prepared to walk away? I can't speak for our governor. We are prepared to negotiate as absolutely seriously, conscientiously as we possibly can to make sure Hoosiers get health insurance and that all Hoosiers are covered.
Good for you. I'm glad to hear that we're all in negotiations with our own federal bureaucrats to get back the money we sent them. Now, we're down. They tell me we're down to 5 minutes. So if you can ask quick questions, we'll try to be concise in our responses, because we've got the exciting show luncheon taking place on the show floor. I'm supposed to encourage everybody here to take their appetite down to the show floor, say hi to the people in the booth. Go ahead with your question and tell us who you are.
Sure. My name is Dawn Hunter, and I am a visiting attorney in public health law at the New Mexico Department of Health. And I was hoping the panel could speak to specifically your state's involvement with the CMS State Innovation Model, either design or test phase, and how that's impacting healthcare innovation in your state.
Good. I hope you guys have an answer to this one. This is...
I think I'll say that the SIM grant, we're at in the implementation, one of the, I think, 7 states that got implementation level grants, and From my perspective, it was a injection of cash to help us do what we were already trying to do. I had some fear that it would steer us away from some of our attempts to do things like global budgets for hospitals, because that's not part of SIM. But I'm assured that we're continuing to work on all of those things. So I think it's been helpful for us.
Quick comment on Utah?
Last year, the governor organized a SIM working group. I participated in that all summer long, unfortunately. But it was a lot of work, a lot of gnashing of teeth. But last month, we submitted for a $66 million innovation grant to try to have better integrated care. And I'm actually very hopeful that we've got some really great ideas. If we get the funding, we'll make some good progress.
Thank you. Our last question. Tell us who you are.
Sean Martin with the Legislative Analyst Office in Sacramento, California. In California, we have a pilot program where we've taken about 300,000 people in our Medi-Cal program, which is our version of Medicaid. They are dual eligibles. We are enrolling them into managed care in collaboration with the federal government. And one of the difficulties we had when we started this was getting the federal government to sign on to some sharing of the savings that we anticipate that they will receive in their Medicare program, mainly through reduced hospitalizations. So it's interesting if you've seen any movement lately in terms of the federal government being more forthcoming in sharing savings that are achieved in Medicare when states take these innovative approaches.
I'm going to give this one to Ray first, because he's probably the most generous.
That was who I thought could answer, yeah.
You got to remember, this is an OMB thing more than it is an HHS thing. So that would be, they'd be cutting down their potential revenues. So I don't see much movement unless there's new legislation in this area.
Thank you.
We've had it's been a long battle over every one of the waivers, and so they've never moved off that budget neutrality. And it's too bad, because there's a number of state experimentations out there that could prove very helpful, in terms of this current waiver that we're talking about. But I don't see them moving.
Yeah, I'd like the panel to thank the audience. This is not normally done, but we should thank our audience with a round of applause. Now I'd like to ask the audience to thank these four distinguished panelists for their